The hope is that these new drugs represent not the solution, but the beginning of a new era where we can actually modify the biology of Alzheimer's and hopefully other conditions that lead to dementia. And in the future, that we might not only slow decline in people who have symptoms, but we might actually prevent symptoms from ever happening if we can intervene early enough in a safe way and in an economically feasible way.
Hi, I'm Derek Angus, a physician and senior editor at JAMA. You're listening to Healthy Dialogue, a new podcast from the JAMA network, where we'll be discussing some of the most pressing issues in health and healthcare with leading experts from around the world. I have to say, for me, and I think for a lot of people, the idea of developing or having a loved one develop dementia is really incredibly scary. That someone could still be alive and yet becomes lost to you is just so heartbreaking and scary. And yet, for all of our fears, I also suspect that many of us don't actually know that much about dementia. The clinical definition of dementia is a decline in memory or other cognitive abilities that interferes with the ability to function independently in day-to-day life. Initially, that means that people end up requiring assistance with complicated tasks like finances, managing calendars, or appointments. But over time, as the dementia progresses, then people start requiring assistance with more basic activities like hygiene, toilet, eating, dressing, etc. There's about 7 million Americans and 60 million people worldwide who have dementia, and a similar number with the earlier stage of mild cognitive impairment, even though they might still be independent in daily life. So today I thought it would be useful to chat with someone who can really weigh in on a whole bunch of questions that we might have about dementia. I'm delighted to spend the next little while chatting with Gil Rabinovici. Gil is the Edward and Pearl Fine Distinguished Professor of Neurology and Director of the Alzheimer's Disease Research Center at the University of California, San Francisco. Gil is also an associate editor at JAMA. We're going to discuss risk factors and causes of dementia, the relationship of Alzheimer's disease to dementia, how sleep and other lifestyle factors come into play, and we'll talk about early detection and treatment, including some new drugs. Gil, welcome.
Thank you so much. Really a pleasure to be here.
So Gil, the first thing I want to get my head around is how likely is it that someone will actually get dementia? You know, we all see the examples in the television, we all hear of cases, but what is the actual frequency, the incidence of dementia? What is someone's risk? And is it changing? Do we think it's becoming more common?
Yeah, these are great questions. The lifetime risk at age 65 is somewhere around 11%. And that translates into approximately 1 in 5 women and 1 in 10 men living at age 65 who may develop dementia during their lifetime. So the prevalence and incidence rival any of the most common age-related health challenges that we face as individuals get older. The prevalence of dementia is increasing, and that is because people are living longer. So as we'll discuss, the number one risk factor for developing dementia is older age. And as more and more adults live into their 80s or 90s or even longer, their risk of dementia increases exponentially. And so the prevalence is increasing. But the good news is the incidence might be decreasing when you think about age-specific incidence. And there are a lot of data to suggest that. And we think that the incidence is decreasing because we are doing a better job primarily of treating vascular risk factors, which are a major contributor to an individual's likelihood of dementia. So we are making headway in modifying some risk factors at the same time because people are living longer. The overall prevalence of dementia is increasing.
Okay. So if a woman and a man lived the same length of time, would they have an equal risk? Or is it just that because women live longer, they have a greater and longer chance to get dementia?
It seems that the increased survival is part of the story, but not the full story in terms of the higher risk that women have for developing dementia. There are probably some historical elements to this. So one of the protective factors actually against developing dementia is educational attainment. And older women now are of a generation where on average women had less educational attainment than men. Hopefully we've closed that gap entirely now, but that is still something that older generations are dealing with. So that may be part of the story. Part of the story does seem to be hormonal. So loss of estrogen, menopause can directly impact brain areas that are susceptible to dementia. And then there are some interesting genetic interactions between biological sex and specific risk genes for Alzheimer's disease and dementia, such as the apolipoprotein E4 gene, where having that risk gene has a stronger impact on females than males. And so there are a whole host of factors, societal, lifespan, but also clearly biological, that differentially impact the risk across different sexes and genders.
So there's not much we can do about our underlying biology, but I am intrigued by your comments about educational attainment. First, we may not only have narrowed the gap between men and women, we may have flipped the script. I think today, young American men are less likely to complete a 4-year college degree than women. But there are other differences in society in terms of educational attainment. For example, differences by income and by socioeconomic class. So I wanted to ask Gil, do we also see that educational attainment or socioeconomic class in general is a risk factor for dementia?
Definitely. So it's not just years of education, but quality of education. There are studies that have shown that individuals who go to higher quality schools by different metrics have greater protection. And that, of course, is largely driven by historical inequities in our society, as well as socioeconomic status. Being the subject of chronic stress can impact your risk of dementia. Facing discrimination or trauma can impact your risk of dementia. And so there are many social determinants of health that over the lifespan affect an individual. The amount of air pollution that you live in throughout your life directly affects the health of your brain and the likelihood of developing dementia. And of course, individuals who are of lower socioeconomic status are more likely to live in areas that have higher rates of pollution. So this is very deeply intertwined with social determinants of health.
Okay, got it. Are there other risk factors? Are any of them modifiable?
The Lancet Commission recognizes 14 modifiable risk factors for dementia. And really, these risk factors are encountered throughout the lifespan. So we talked about educational attainment, vascular risk factors, in particular, high blood pressure, diabetes, obesity, high cholesterol. All of those directly impact the health of the brain throughout your life and can impact an individual's risk of developing dementia. Experiencing depression seems to be a risk factor. Use of tobacco or alcohol is a risk factor. Physical inactivity, experiencing a traumatic brain injury, even a single mild traumatic brain injury, can slightly increase the risk of developing dementia over life. And then as individuals age, loss of hearing, loss of vision, and social isolation also contribute to the risk of dementia. And so it really is things that we are exposed to throughout our lifespan that seem to modify the risk of dementia. And many of these are strongly intertwined with social determinants of health. When you think about vascular risk factors, even access to healthcare is going to make a big difference in terms of detecting and optimally treating different vascular risk factors like high blood pressure. And so this is all intertwined. And the good news is that these are modifiable at an individual level and hopefully at a societal level through good health policy. And it's been estimated recently that up to 45% of all incident cases of dementia can be directly attributed to one of these 14 modifiable risk factors. So if we were to eliminate high blood pressure, diabetes, et cetera, we could actually reduce the overall rates of dementia by almost 50%. And I think that's good news. And that's where we are making headway, in particular with treating vascular risk factors. And that is why, as I mentioned, it seems like the age-specific incidence of dementia is decreasing. But again, the prevalence is increasing as people live longer.
So I agree. That sounds really good news. Now, you've brought up a couple of times vascular risk factors, but you've also brought up factors that seem to be related to just how much we use our brain, things like social isolation and so forth, which presumably means how much you're firing your brain, interacting in conversation with people and so on, can play a role in causing or not causing dementia. You also mentioned traumatic brain injury as a cause. These risk factors are all quite disparate from each other. I can imagine vascular dementia has something to do with impaired blood supply, damaging brain function via compromised oxygenation of brain tissue. Presumably, traumatic brain injury is a cause of dementia via direct mechanical destruction of parts of the brain, or perhaps something goes awry as the brain tries to repair itself after injury. But all these different types of risk factors make me wonder, what are the causes of dementia? Are there different flavors of dementia? And do some causes cause different kinds of dementia?
There are many different causes of dementia. There are sometimes reversible causes. There are certainly many medications that older adults take that can interfere with how the brain functions and cause memory loss because it's directly interfering with brain activity or with brain networks that are important for memory. And so occasionally, if people are on a lot of medications, as many older adults end up being on, we call it polypharmacy, many medications. Medication side effects can interfere with cognition to the point where people might actually meet the criteria for dementia. There are medical conditions that can contribute to dysfunction of the brain and cause cognitive decline. And these are major organ failures. So people who have really significant kidney disease or lung disease or heart failure, and their brain isn't getting the right amount of oxygen or isn't getting adequate blood flow from the heart, or the kidneys aren't detoxifying the blood from all the different things that they need to do, that can cause symptoms. And so as a clinician, when someone is coming to see me, my first question is, can I identify something potentially reversible, a medical condition that could be treated better, a drug side effect? And even if that isn't the whole story and doesn't fully explain why someone is experiencing cognitive difficulties, it still might be an important component. And as a physician, if I can reverse that or improve the treatment of a certain condition, that can certainly benefit patients. There are vitamin deficiencies, hormone deficiencies that are quite common. The most common things that we look for are hypothyroidism or low thyroid function. That can impact cognition. Vitamin B12 deficiency, that can really impact the brain. And so as a doctor, that's my first pass is there anything reversible that I can identify here, either based on the medical history, the medication history, or based on some basic blood tests to rule out simple things that we could treat easily.
Okay, got it. So what's the difference between Alzheimer's disease and dementia?
The most common cause of dementia in older adults is Alzheimer's disease. Alzheimer's disease refers to a very specific biology, which is the accumulation of toxic proteins in the brain called amyloid plaques and tau tangles. These proteins start to accumulate in the brain years, even decades, before people have the earliest signs of memory loss. And these proteins, as they deposit in the brain, interfere with brain function, can cause loss of brain tissue or brain atrophy. And over many years, people might develop a decline in their memory or cognitive abilities and develop dementia. So Alzheimer's disease, as defined by plaques and tangles in the brain, is the most common cause of age-related dementia. As you referred to, there are vascular causes of dementia due to plaque buildup in blood vessels in the brain, that if a blood vessel gets blocked, that can cause an acute stroke. We know what that looks like. People suddenly lose their ability to talk or walk or move one side of their body. But if over time, the blood vessels are chronically narrowed and deep parts of the brain are not getting adequate blood supply, that can cause scar tissue in the white matter of the brain, which are the cables that connect the brain cells to each other and allow them to communicate as networks electrically. And that can lead to cognitive changes. So we talk about vascular contributions to dementia. And then there are other toxic proteins that deposit in the brain that can also be toxic to the brain and lead to loss of brain tissue. And so all of these different proteins can contribute to brain dysfunction. They cause different symptoms, and over time, they can contribute to dementia. And what we've found from many studies now is that when people develop dementia in older age, it's usually not just one of these potential conditions, but multiple conditions that together are contributing to brain dysfunction and dementia. And so in older adults who die with dementia, it's just like when you take your car to the mechanic, right? And you find there's not just one thing wrong, there's 3 or 4 things that they find. When you look at the brain under a microscope after someone with dementia has passed away, you might find some changes of Alzheimer's disease, some changes consistent with Parkinson's or Lewy body, some vascular injury. And so more and more we're understanding that it's these different toxic proteins and biological pathways that over time contribute to brain dysfunction and ultimately to dementia. And as we think forward about diagnosis and treatment, we're probably going to need to address all of these different factors in order to make a big difference in someone's cognitive outcomes. It may not be enough, even if we could eliminate, say, all the vascular disease, right? There still would be some of these other toxic proteins. Or if we could eliminate all the Alzheimer's changes, there still would be other pathways. And so we have quite a challenge ahead of us, but we're also making excellent progress, especially in some of these conditions.
Okay, I'm still trying to understand here. So when you talk about modifiable risk factors, some of those risk factors, like controlling blood pressure to avoid hypertension, controlling lipids to avoid hyperlipidemia, I see these as clearly related to protecting the vasculature and therefore presumably to decreasing risk factors for vascular dementia. Does that mean that the other risk factors relate in some way to somehow that they are driving this deposition of these unwanted proteins in brain tissue?
It's pretty complicated. The vascular is sort of the easiest to wrap your head around. So one way that you can protect your brain against getting dementia is by building what we call your brain reserve or cognitive reserve. So literally, we think that when you're using your brain more throughout your life, either through education or occupation, you're actually building more connections or synapses in the brain. And so if as you get older, you're starting to lose some of these connections, you have more to spare, if you will. You have more reserve. Even if the brain is developing some of these pathologies or vascular changes, your brain has more reserve to begin with. And so you're going to have a better cognitive outcome as you get older. Exercise, we think, might fall under that category. It certainly can improve your vascular health, but it also, when we exercise, the brain releases growth factors that promote plasticity and new connections and might make the brain more able to withstand some of the other pathologies that occur as we get older. Some of the modifiable risk factors may contribute directly to the deposition of some of these toxic proteins. For example, when someone has a traumatic brain injury, that can lead to inflammation and release of proteins, and those can be quiescent, but over time, as people age, the proteins might deposit and spread through the brain. Air pollution is another risk factor that might directly contribute to inflammation in the brain and either serve as the basis for these proteins starting to accumulate or facilitate their more rapid accumulation. So it's a complex interplay, I would say, between cognitive reserve, vascular pathways, other pathologies that are developing in the brain, and these different social determinants of health and life exposures that we go through.
That's very helpful. So if our brains are like a water supply system, we need to make sure there's a power supply to pump the water. The power supply is the vascular system. No power, no water. We also need the water to be held in a reservoir. If the reservoir fills with silt, then even if we have power, we only get mud. We fix that by making sure the reservoir is big enough that even if silt accumulates at the bottom, there's still enough water for all our needs. And we put filters in place to try to slow the rate of silt accumulation.
Definitely. Another really important aspect that we haven't touched on yet is sleep. We still don't fully understand why we need to sleep, but we clearly do. If you sleep deprive animals, they basically die. And we think that one of the functions of sleep might actually be, that might be the time where the sanitation department is going through the brain and clearing some of the waste. So there are interesting studies, both in animal models and in humans, that suggest that during sleep, we can actually clear some of these toxic proteins, amyloid and tau, that later form plaques and tangles. So sleep disorders are a risk factor for dementia, and conversely, having good quality sleep can actually be protective. So a lot of different factors, some under our control, some less under our control, that over time might modify the risk of someone developing a clinically significant decline in dementia.
Okay, so that's very helpful. So let's move on from the causes of dementia to start talking about presentation and diagnosis. And Gil, I don't want to presume this happens to you, but I certainly have moments where I am completely unable to think of a word that I feel should be on the tip of my tongue. And I think, my gosh, my brain is not working the way it used to. Is this something serious that's happening to me? Now, you spoke about the slow, insidious onset of dementia. How do we know when these little moments, for example, moments of forgetfulness, represent just something normal, something maybe from a little sleep deprivation, as opposed to representing a true early warning sign of impending cognitive decline? In other words, if you notice that you or your loved one can't remember a name, when should you be worried? When should you be calling the doctor?
These are really key questions that all of us face. So all of us have experienced, I think, the inability to find the right word. I've experienced it just a few times during this podcast. We all experience a moment when we're trying to remember the name of an actress in a film that we saw, and it's just not coming to us. So these sort of tip of the tongue difficulties of finding the right word, thinking of the name of someone that you don't think of very often in that moment, those are very common, and they're more frequent as people age. And of course, our brain is a diva. It really requires an optimal environment. And so if we have a poor night's sleep, or we're a little bit sick with the flu, or we're experiencing more stress, or maybe we're a little bit depressed, all of those things can impact and bring on some of those symptoms. There are, however, symptoms that really raise my antennae when I'm listening to a history from a person or a family member. When people are forgetting events, they attended a birthday party and 2 weeks later, they have no memory of that. You had a conversation the night before about coming to the memory clinic in San Francisco, and the next morning, they don't remember the conversation. They don't remember the fact that they have an appointment scheduled. Those are more concerning symptoms for pathological, what we would say, memory loss, or memory loss that might be related to a real neurological or medical condition. Repeatedly missing important deadlines or appointments, sometimes paying the credit card bill twice, those can be real red flags. If people are confused about the day or day of the week or dates, if people are suddenly showing real lapses in judgment, these are all concerning symptoms. Sometimes the earliest symptoms of some of these conditions that cause dementia might not be cognitive. It can be psychiatric, changes in personality, changes in someone's behavior. Sometimes a new onset of depression or anxiety in someone older can actually be a prodrome to some of these conditions. And these are things that as clinicians, we try to pick up on as we interview a patient or a family member. We usually try to interview both, by the way, together to get different perspectives, because sometimes someone might not realize actually when they're experiencing memory loss. They might forget that they're forgetting, and yet it's very apparent to a family member or a close friend. So we try to get these different perspectives in the clinical history. And we ask about some of the symptoms that we find more concerning and try to dissociate them from some of the very common symptoms that people have, quote unquote, senior moments that we all experience.
So we've covered a lot about risk factors, about symptoms, and about rates of dementia. But we've certainly been hearing that there's been a lot of progress these days in the diagnosis and treatment. And so in this last segment of the episode, I wanted Gil to walk us through the diagnostic process today, how it's evolved in recent years with the advent of blood tests for amyloid plaques and for tau proteins, and with diagnosis, what now we can say about treatment. We've seen major advances in drugs for treating dementia, and something else that's coming to the forefront of the conversation, lifestyle modifications. So let's dive back in with the initial diagnosis.
So the first thing that we do is more formal cognitive testing. There are some brief screens that we can do in the doctor's office that take 5 or 10 minutes, and those are pretty good at picking up dementia. They're not as sensitive at picking up earlier stages of what we call mild cognitive impairment, or that earlier cognitive decline that doesn't meet the threshold for dementia, but is still clinically relevant. Then there are batteries of neuropsychological tests that are done to assess an individual's cognitive abilities in different cognitive domains. So not only their short-term memory, but we also test language abilities, we test spatial abilities, we test what we call executive functions, the ability to focus and concentrate, process complex information, multitask and switch between one task to another. These are all testing really different brain networks, and different neurodegenerative conditions can impact different brain networks and cause different types of cognitive symptoms. And so we screen all of those things. We also ask questions about changes in personality, behavior, and psychiatric symptoms, anxiety, depression. Sometimes people might even develop delusions or hallucinations with one of the more common causes of dementia besides Alzheimer's, which is dementia with Lewy bodies. So that's the first step, is really to do neuropsychological testing.
Okay, so beyond taking a history, examining the patient, and performing neuropsychological testing, what blood tests or medical imaging might a physician order?
We do blood tests to rule out the simple things that we can treat, the vitamin B deficiency, the low thyroid hormone. These are things that, when we detect them, can make a big difference if we treat them better. And then we do some form of brain imaging, either a CT scan or most often an MRI scan. And what we're looking for there are any structural changes that can, A, be treated. For example, it's rare, but sometimes people can develop cognitive changes because they have too much water in the brain, a condition we call hydrocephalus. So that's something that we could potentially treat. There might be a lesion, a growth in the brain that's pushing on the brain and impacting function. And so we do the imaging to rule those things out, but we also look carefully at different brain areas to see if we can identify any tissue loss or atrophy, in particular in parts of the brain that are important for short-term memory, if that's the symptom someone's experiencing. And we're also looking for vascular changes, so any evidence of strokes or silent strokes or vascular injury, as we discussed earlier. That's the first round of tests. What the real breakthrough in the last couple of decades is, however, the ability to directly detect some of those bad proteins. And we can actually detect the plaques and tangles of Alzheimer's disease years before people develop memory loss. And there are different ways of doing that. Initially, The detection required actually doing a lumbar puncture, or what's known as a spinal tap, and measuring the concentrations of the amyloid and tau protein. These are the proteins that form plaques and tangles in the spinal fluid. Then there were specialized brain imaging tests that were developed in the mid-2000s to mid-2010s called PET scans, where you inject a radioactive molecule that lights up amyloid plaques or tau tangles in the brain if they're present, and can show you where they are and how much of the protein has accumulated. And really, just in the last 5 years, there's been remarkable progress in developing blood tests that are measuring the concentrations of the amyloid or tau protein in the blood. And these are about 90% accurate compared to the more complicated brain scans or even autopsies at detecting plaques and tangles in the brain. And so specifically for this question of Alzheimer's disease, we now have diagnostic tests that can directly identify these changes and help us either rule out Alzheimer's as a cause of someone's cognitive decline or rule it in as a contributing factor or a main cause. And that might trigger a specific treatment. So the first step in effectively treating a condition is diagnosing it accurately and early. Before we had access to these direct tests for Alzheimer's disease, even experts were only about 70% accurate at determining what the cause of dementia is in life. So you can imagine how hard it was to develop or test different treatments. A, if we were making the diagnosis late at the dementia stage, and B, if the accuracy even at that stage was only 70 or 80%. So now we can get higher than 90% with some of these additional tests, and we can also treat these pathologies much earlier. So if someone comes in with the earliest symptoms of memory loss that's concerning, we can do, for example, a PET scan or a blood test and determine if Alzheimer's is contributing to their memory loss. And now that we can make the diagnosis early, we also have new treatments just approved in the last couple of years that directly impact the biology of Alzheimer's disease. And while they're not cures, they can modestly slow the rate of cognitive decline.
Before we get to these new treatments, what about lifestyle changes people can make to slow cognitive decline?
Yeah, so people often ask, is it too late to change my lifestyle if I didn't eat great during middle age, if I didn't exercise enough, if I'm a little overweight, is it too late? Is my fate sealed? Or can I actually change my lifestyle in a way that will change my risk of developing dementia? There have been two major trials now that look at what we call multi-domain lifestyle interventions. So intense interventions that include a structured diet, exercise program, a cognitive activity or brain game program, social engagement, very careful assessment and treatment of vascular risk factors. One was called the FINGER trial that was done in Finland about 10 years ago. And the other was called the POINTER study that was actually published in JAMA just last year in 2025. And both these trials were done in older adults who had an increased risk of developing dementia based on their family history, based on their other risk factors. And encouragingly, what both trials found is that this intense change in lifestyle over 2 years actually led to an improvement in people's cognitive performance compared to people who had a placebo intervention, if you will. It wasn't really placebo. It was just more general counseling about lifestyle and behavior, but without all that structure. And so I tell patients, there is hope. It's never too late. And we actually have good clinical data to suggest that changing your lifestyle, even in older age, can improve cognitive performance. And so that is definitely a universal recommendation for all our listeners.
So let's talk about these new treatments. They've certainly been in the news, both because they had an interesting path to even get FDA approval, and there was a concern, at least with the first one, that these are quite tricky drugs to give, that they sometimes can have a lot of side effects and they involve quite expensive monitoring. What are this class of drugs? Are there more than one classes of drugs? And are we just at the beginning and even better ones are coming? Or what's your take?
Right. So for the last 25 years, we've had drugs that treat the symptoms of Alzheimer's. These are drugs like donepezil. They might be familiar, known. The brand name is Aricept. These are drugs that are very commonly used. They treat changes in brain chemistry that result from Alzheimer's disease. They don't directly treat the plaques or the tangles, and they can help with symptoms or slow the decline in symptoms a bit. And so these are symptomatic medications, very simple to give, a pill you take once a day. And these have been around for a long time and have a very good track record. The new development has been medications that directly change the biology of Alzheimer's. So for the last 15 years, there's been a huge effort to try to develop drugs specifically that are targeting the amyloid plaques. And there's a whole host of reasons why that was a very attractive target for drug development. And in the last 5 years, there have been 3 now monoclonal antibodies. So antibodies that are infused through an IV that get into the brain, and they basically signal the plaques for destruction by the immune system in the brain. And all 3 of these drugs that have been approved by the FDA are very effective at clearing plaques from the brain. Based on what we understand about the biology of the disease, there's a strong premise to believe that if you can remove plaques, you can slow the accumulation of that second toxic protein, the tangles, and additionally then slow memory decline and dementia. And so that was the premise for these drugs. The first drug that was approved by the FDA in 2021 was called aducanumab. That drug is actually now off the market because it was a bit of a disaster in terms of many aspects of its development and marketing. It was the first drug, however, that was effective at removing plaques, but what was less clear is whether it had a clinical benefit. Fortunately, we have a lot more clarity now because there have since been 2 monoclonal antibodies that have the same mechanism of action. They clear plaques from the brain. One is called lecanemab, the other is called donanemab. And both of those drugs, in very rigorously done, well-controlled, phase 3 placebo-controlled randomized trials, showed that there was a benefit in terms of slowing the decline of cognition and function. The effect was modest. It's about a 30% slower reduction in scales that measure a combination of cognition and function. So it's not a cure, and patients don't notice that their memory is getting better. In fact, the memory is likely to decline. But what both of these trials showed in a very rigorous manner was that the rate of decline was slower in people who got the antibody versus the placebo. And both of these drugs received traditional FDA approval based on a rigorous body of evidence that there is a clinical benefit. Again, and I talk to patients about this, the benefit is modest. It's not a home run, but it's maybe a double or a solid single. And many patients, especially in these early stages, if you can slow their decline and keep them, for example, at the MCI or mild cognitive impairment stage where they're experiencing memory loss, but they're still independent, they want to prolong that stage as much as possible for obvious reasons. And that's one thing these drugs do. They reduce the likelihood that someone might convert from having mild cognitive impairment to dementia, so from being independent to dependent, by about 30 to 35%. And that can be clinically meaningful for some patients.
Okay, and what about the side effects?
There's no free lunch, and so these drugs do have side effects that we need to carefully monitor for. And really, the side effects that they cause are related to fluid shifts that occur in the brain that can cause edema or hemorrhage. These are called amyloid-related imaging abnormalities, or ARIA. And they can cause edema or swelling, that's called ARIA-E, or they can cause usually microbleeds that can only be detected on an MRI scan, but occasionally a significant brain bleed, and that's called ARIA-H. The rates of ARIA are approximately 20 to 30%. They're a little bit different in the different trials and with the different antibodies. And about 3/4 of the time, these brain changes are actually asymptomatic. So the way that we detect them is based on doing MRI scans as we start patients on these treatments. And we do MRI scans periodically every month or every couple of months to monitor for these changes. And if we see them, we might pause treatment or reduce treatment. a lot of the time they don't cause any symptoms, but about 25% of the time people can have symptoms. They're usually mild, a little bit of confusion, a little bit of a headache or visual changes, but rarely the ARIA events can be very serious. They can result in a major brain hemorrhage. They can result in seizures. They can result in stroke-like episodes. That's rare. It's less than 1% of the time, but it can occur. And there have been a number of deaths associated with very severe ARIA related to these drugs. And so, like a lot of treatments that we give for people with devastating conditions, these drugs have some modest benefit. They also have some risks, including rare but serious risks and death. And what I do is I have a very nuanced conversation with my patient and with their family to discuss the potential benefits and risks, what we know and what we don't know, and allow a shared decision-making process to take place where any individual might decide, well, I will do anything basically to slow this down, and I'm willing to take these risks. Other patients will say, the minute you say brain bleed, they're like, I'm out, not interested. So this isn't dissimilar, right, to how we have approached other devastating diseases. Think about the first treatments for HIV, for example. They had really bad side effects. They were only modestly effective, but they opened the door to better, safer, more effective treatments. The same analogy can be made for cancer. And so the hope is that these new drugs represent not the solution, but the beginning of a new era where we can actually modify the biology of Alzheimer's and hopefully other conditions that lead to dementia. And in the future, that we might not only slow decline in people who have symptoms, but we might actually prevent symptoms from ever happening if we can intervene early enough in a safe way and in an economically feasible way. So imagine a day in the future where someone at age 70 takes a screening cognitive test and a screening blood panel that looks for some of these proteins, amyloid, tau, synuclein, TDP, that darn protein. We get a panel that tells us what's going on in the brain of that individual, even before maybe they have any clinically meaningful symptoms. And then we can intervene with, say, an oral medication, like a statin, for example, that we use to lower cholesterol. Well, we can give a pill to lower your amyloid and lower your tau. And the hope is that those types of early interventions might actually prevent the development of cognitive impairments. That is actually not science fiction. There are currently clinical trials being done in older adults who have evidence of amyloid in their brain with these approved antibodies, lecanemab and donanemab, to see if treating people before they develop clinically meaningful symptoms might actually reduce their risk of developing cognitive impairment. And we're going to have answers to that question actually very soon, in the next 1 to 2 years. So it is an exciting time now. Just to try to wrap things up, dementia, as we discussed, is a very significant problem. It is the most feared disease. Studies bear that out by older adults. That said, I think there's a lot of room for excitement and optimism. We can think in the future about a brain health visit that you do with your primary care doctor where they assess all these modifiable risk factors and prescribe a variety of different treatments, including modifying your vascular risk factors, maybe an exercise program, dietary changes that can reduce your risk of developing dementia. And then we can think about detecting some of the biological processes that lead to dementia before people have any symptoms and intervening with effective treatments for individual patients. And I think in 10 years, if you invite me back to this podcast, we're going to have a very different conversation, which is going to involve a lot more prevention and I think a variety of different drugs that are targeting different pathologies that can help not only treat, but ultimately prevent dementia.
Well, on that note, Gil, I want to thank you immensely for spending some time with me. I feel like I have a far greater understanding of where we are with dementia right now. And as you alluded to, this is an incredibly exciting horizon. I think for many of us in clinical practice, we've spent the last few decades of our career seeing essentially no change in the field of dementia. And now there's massive change and tremendous reason for optimism on the horizon. Thank you.
Thank you. Pleasure to be here.
Thanks for tuning in to this episode of Healthy Dialogue. I'm Derek Angus, and I've been speaking with Gil Rabinovici. To learn more about JAMA Network research on dementia, check out the resources linked in our episode notes. You can also email us questions related to this podcast at healthydialogue@jamanetwork.org. If you'd like to continue today's conversation, please subscribe, rate, and share this podcast. This episode was produced by Daniel Musisi, Daniel Morrill, and Matthew O'Connor at the JAMA Network. Until next time, thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.